Assalamu alaikum. I hope that you and your family in the best state, and I hope that this lockdown will end immediately in order to return back to our normal life. Anyhow, in the previous lectures, I'm with you discussing the red blood cell disorder, white blood cell disorder, and from this lecture to I will discuss the platelet disorders. So, a platelet disorder. And platelets, as you know, produced from the third bone marrow lineage cell, the megakaryocytes. Megakaryocytes, which is the largest bone marrow cell, and this produce from 2,000 each cell, each megakaryocyte produce from 2,000 to 5,000 platelets. And the main function of platelet is to prevent hemorrhage. Excessive bleeding, especially after injury. And how platelet do that, I will explain it in an abbreviated manner. As you know, this provided that this blood vessel and injury occur here. The blood vessel, usually in the blood, there is 4 components interact with each other, counteract the effect of each one, like endothelium and prostacyclin from one side, and the opposite is thromboxane A2 and ABD. IDP. Endothelium and prostacyclin, their main function is vasodilatation and preventing the platelet from being adherent to the endothelium. While thromboxane A2 and adenosine diphosphate, ADP, their function is vasoconstriction, hypertension, and platelet aggregation. Normally, normally in a normal vessel, endothelium and the prostacyclin are dominant. When injury occurs, what happened when injury occurs? When injury occurs, like this, blood vessel, cut in the endothelium, that's mean there is some endothelial tissue exposure, and in the subendothelial tissue there is a factor called von Willebrand factor. And this von Willebrand factor attached to the platelet receptor called the glycoprotein 1b. Glycoprotein 1b. So this von Willebrand factor attached to a receptor in the platelet called von Willebrand 1b. And by this process, the platelet will be adherent to the endothelial tissue. And once the platelet adherent to the endothelial tissue, they are activated these platelets, after being adherent to the subendothelial tissue by attachment of von Willebrand factor to the activated glycoprotein 1b, cause activation of the platelet, and activation of platelet make them produce thromboxane A2 and ADP, adenosine diphosphate. So in injured vessel, the thromboxane A2 and adenosine diphosphate become dominant. In addition to that, the activated platelets start to expression another glycoprotein called glycoprotein 2A, 2B3A. 2B3A. And now thromboxane A2 and ADP start to recruit the platelet from other parts to the site of injury. Recruit platelets and activating this platelet to produce again more thromboxane and ADP and expression glycoprotein 2B3A. And glycoprotein 2B3A attached to fibrinogen. Another platelet also attached to the fibrinogen, another platelet, another. This is called aggregation. So we have two stages of primary homeostasis. First, adherence through glycoprotein 1b and von Willebrand factor attachment, and the second stage through activation of glycoprotein 2b3a and its attachment with fibrinogen and the recruitment of other activated platelets attached with fibrinogen, causing aggregation. So we have adhesion and aggregation. In fact, aspirin act on thromboxane A2, inhibit thromboxane A2, while clopidogrel inhibit ADP, act on this, inhibit ADP, negative. While abciximab a glycoprotein 2b3a antagonist act on this receptor, causing increased bleeding time and preventing platelet aggregation. This is, in short, the primary hemostasis. And this is important, in fact, to discuss the von Willebrand disease. Which is autosomal dominant condition of disorder in which there is either a qualitative or quantitative von Willebrand defect. Qualitative deficiency. Qualitative, that's abnormal. Quantitative deficiency of the amount reduced. And when this deficient, the first step in adherence usually impaired, and there is no attachment of the platelet to the subendothelial tissue, which is mediated by von Willebrand glycoprotein 1b attachment, and the result of that increase in the bleeding time and the result of increasing the bleeding time is development of superficial bleeding. Superficial bleeding, like ecchymosis, purpura, or petechiae, when the spots from 0.3 and less, from a millim, from 0.3 to 1 cm, it is purpura. When more than 1 cm, it is ecchymosis. And this is skin and gingival bleeding, vaginal bleeding, almost superficial, or epistaxis. All these are manifest as superficial bleeding, mostly due to defect in the primary hemostasis, and it is mostly due to platelet defect. And the most common congenital platelet defect is von Willebrand disease. It is autosomal dominant, and the defect is in the step 1, attachment of glycoprotein 1b to von Willebrand factor, which is defective either in the quantity or in the quality. اكو third type طبعا autosomal recessive. The third type is severe, and it's similar to hemophilia, but this is better to know. How would we diagnose? حقيقة diagnosis by أول شيء bleeding time prolonged, coagulation panel normal عادة PT and PTT usually normal, sometimes PTT prolonged, some قليلة, and through ristocytine test. Ristocytine antibiotic used previously, but it used now. No longer used as antibiotic, used now in platelet function determination. It's usually added when we take a serum from the patient and platelet and give ristocytine, and there is abnormal ristocytine because there is no fibrinogen, and this abnormal ristocytine aggregation test will be corrected once we add serum from normal person. So serum from normal person usually contain von Willebrand factor, and normal platelet contain glycoprotein 1b, so aggregation will occur. So once we give add normal serum to the abnormal ristocytine test patient, it's corrected, the aggregation corrected, that confirmed diagnosis of von Willebrand disease. How would we treat, in fact, either we add desmopressin and desmopressin increase the von Willebrand expression and factor 8 طبعا 8 expression. Avoid NSAID, non-steroidal anti-inflammatory drugs, or sometimes we might need to give platelet transfusion The second congenital defect in the platelet هو Bernard-Soulier syndrome. Bernard-Soulier syndrome, and this is autosomal recessive condition, while von Willebrand is autosomal dominant. It is very rare, in which there is a mild reduction in platelets count. So it is autosomal recessive condition. It is rare, and there is mild reduction in platelet, and the platelet size usually large. Bernard-Soulier syndrome. The defect in Bernard-Soulier حقيقة هو مو بالفون ويلبراند فاكتور. defect هو بالجلايكوبروتين 1B. إذا البليتلت defect هي أيضا بالفيرست step of adherence defect in glycoprotein 1B receptor. So there is von Willebrand factor, but there is no glycoprotein 1B. The result is abnormal adherence of platelet and in prolonged bleeding time. How would we confirm the diagnosis حقيقة؟ أول شيء restocytin test usually abnormal. When do add the restocytin, which enhance aggregation of platelet to the von Willebrand factor, there is abnormal because there is no glycoprotein 1B. So abnormal restocytin test initial, and this not corrected even when add a normal serum, because normal serum contain von Willebrand factor, and this condition there is no problem with the von Willebrand factor. The problem is in the glycoprotein 1B receptor. So when we add serum, addition of serum, the aggregation usually not corrected. Not corrected. Again, the presentation of this patient, clinical manifestation, is similar حقيقة to von Willebrand. There was superficial bleeding, petechiae, purpura, ecchymosis, gingival bleeding, vaginal bleeding, epistaxis. Just similar to that of von Willebrand. And treatment, usually here desmopressin is without benefit, because desmopressin just increases the von Willebrand factor expression and factor 8 expression, and here there is no problem with the factor 8 von Willebrand factor expression. The problem is in glycoprotein 1B. So there is عادة desmopressin without benefit. The same avoidance of non-steroidal anti-inflammatory drugs, and sometimes we might need to give platelet transfusion. Platelet transfusion. The third hereditary platelet defect حقيقة هو بالجلانزمان ثرومبوستينيا. Glanzmann thrombostemia. Glanzmann thrombostemia. And here the defect is on glycoprotein 2B3A. And please remember, that in primary hemostasis there is two stages, more than two, but more than two stages حقيقة in fact. But what is relevant to our lecture is a defect and the primary hemostasis. There is two stages. The first adherent, when there is von Willebrand factor attached to the glycoprotein 1b, and this is called adherence. Aggregation, when the glycoprotein 2b glycoprotein 2b 3a activated, and this glycoprotein 2b3a cause حقيقة attachment of a platelet to the fibrinogen. So platelet, fibrinogen, platelet, يسموها aggregation. The first step. So the defect, in fact, in Glanzmann thrombosthenia is in glycoprotein 2b3a, and that's just similar to a patient taking apixaban for very long time, for his whole life. Apixaban which inhibit glycoprotein 2b3a. Again, the precipitation is similar. This is autosomal recessive. Recessive condition. Autosomal recessive condition. Manifested in the similar to the previous two diseases as bleeding, superficial bleeding, in form of petechiae, purpura, ecchymosis, vaginal bleeding, gingival bleeding, and epistaxis. Again here, desmopressin is without benefit, because desmopressin just increases the expression of von Willebrand and factor VIII, so desmopressin without benefit. And again, we should avoid non-steroidal anti-inflammatory drug use. Platelet transfusion probably of help. I hope that this will be clear in order to continue discussing acquired platelet. This is hereditary platelet disorder concentrated in three conditions. Von Willebrand disorder, when there is defect in von Willebrand expression, responsible for the attachment of von Willebrand factor to glycoprotein 1b, and this is autosomal dominant, usually treated by the use of desmopressin. Non-steroidal anti-inflammatory drug should be avoided, manifested as superficial bleeding. The second is Bellin-Sollier syndrome, when there is defect in the glycoprotein 1b, and here usually desmopressin without benefit, and Glanzmann thrombosthenia when defect in glycoprotein 2b3a, and here again desmopressin without benefit. I hope that this condition, these three disorders are clear. Thank you very much.